This is going to be an awfully difficult one to live up to, both the introduction and Bryn's talk, particularly Bryn's talk. So I'm lost for words, and I hope it doesn't take a stroke for me to get my words back. Can't even find.
It was my intention, Christine, as you realise.
Okay. So my remit is to talk about stroke research, past, present, and future. And a lot of what I'm going to talk about is going to be known to the medical professions here, and some of it will have been experienced by patients who are attending. This is a past a stroke, and this is over 100 years old, but even as recent as 20 years ago, the philosophy was very much the same. You've had a stroke, that's it. You'll either die, you'll be in an institution, your life, as you know it, is at an end. And medical professionals used to avoid stroke patients pretty rapidly, because for a doctor, there's nothing more frustrating than a patient where you can't do anything. So stroke patients were not very popular because there's nothing we could do, nothing the nurses could do, and you just wait for nature to take its course. Research has made a big difference about that. Now, from just waiting and seeing, we're very active. We're not just going towards these patients, we're running because there's something to do. And that's made a difference. More active treatment. The national audit has shown that mortality has over halved in 10 years or so. In 2002, we didn't even bother measuring it nationally, but it would have been somewhere between 30 and 34% in the West Midlands because we had a local audit there. And year on year, you can see how mortality is coming down. In 2014, the national audit has had some problems, but we think we're at about 13%. It might be lower now. It might be as low as 11% nationally now, but the data aren't out yet. Research, as Toby said, benefits everyone. Patients involved in research have better outcomes, whether they get the active treatment or the dummy treatment. Research active stroke units provide a better service, and hospitals which support research perform better. Start with the positive results, and I don't have to restrict myself too much because there's only 3 trials so far which actually have made a big difference about patient outcomes, or 3 trials, 3 types of trials. The first one is stroke units. The initial trials of stroke units were mostly negative because they were small, but once somebody got the idea that you do a meta-analysis, which means you lump the data from 10 or more studies together, these are all the studies of stroke units, and that shows that there is a significant benefit from patients being cared for in stroke units and specialised units rather than anywhere else in the hospital. And that has led to a major reorganisation of stroke services, which stroke survivors here will have witnessed, and the stroke units which you will have attended and where you're working in. This is the biggest change in stroke care. But hot on the heels of that is some research which has been published at about the same time. Thrombolysis. Most strokes are caused by blood clots flying off into the brain, blocking up an artery, and that artery cannot feed that bit of brain, and that bit of brain dies, causing a stroke. If you dissolve that clot, causing the stroke in time, or if the clot is removed by other means, you can reverse a stroke completely and the patient can be cured. But that's totally time dependent. When these results came out in 1995, and even in 2000 when I went to an international stroke conference, people told me that there's no point in doing this because it's expensive. The Americans do that sort of things. We can't do it. We can't scan. And it's taking us 10 years to now get up to a national rate of about 15% of thrombolysis. It's likely that not many more patients will be able to fit, possibly up to 30%, because not every stroke fits the criteria for the treatment. But to be able to allow more patients to benefit from this treatment, we and many other centres in the UK were involved in a large international trial, the IST3 study. This looked whether looked at the question whether the clot-busting treatment, which has already been shown to be effective, can be expanded to other groups which previously haven't been able to benefit from the treatment. The older people, over 80, patients with very severe strokes, and possibly it's a time, normally the treatment has to be given within 4.5 hours. Can we extend the time of treatment to 6 hours? The first two questions were answered positive. Yes, there's no difference between the older and the younger, just as much benefit. Severe and mild strokes can be treated just the same, but I'm afraid the time issue is still there. Moving the treatment towards 6 hours, every minute lost loses brain cells. After 4.5 hours, the chances of benefit are absolutely minimal. Best chances of benefit are within the first 90 minutes. So part of the reorganization of the stroke services is speed, getting the patients to the doctors and to the scanners as quickly as possible. The second part, the second positive trial was the decompressive hemicraniectomy. This is something you probably haven't known about, but I've just put it in because it is so dramatic. You need to treat 4 patients to save 1 life. No, 2 patients to save 1 life if you treat the under 60s. And this is part of a stroke. Initially causes swelling in the brain. The brain swells up, presses on the brain stem, which maintains life, and that pressure itself causes death, usually within 2 or 3 days of the stroke. If the pressure is relieved by taking the bone off, the patient can survive, although the stroke will not recover because this is an effect of a severe stroke. So these operations are now approved by NICE. They are done regularly for patients who require that. For the local population, this will be in the Queen Elizabeth Hospital in Birmingham. But dramatically effective treatment when required. This is just another systematic review which has shown that. And more hot off the press, initially we thought this is only relevant for people under the age of 60, but this more recent study has shown that even patients over the age of 60 may benefit. We need to treat 4 to save 1 life. And here comes almost the hottest of the press, thrombectomy. This has been researched for almost 10 years now, but the first trials have only come out a few years ago, and a whole series of trials has come out this year. 7 trials have been published. What is done here is that it's again about removing this thrombus which is causing the stroke. Thrombolysis resolves the thrombus enzymatically, and as you can imagine, it takes a while for the enzyme to work its way through the thrombus. If you remove it mechanically, you put a catheter in, you pull it out, you can have a thrombus out within half an hour. Or you can have a thrombus out which does not resolve with the thrombolytic treatment. So this is a completely new therapy. I'll just show you the pictures here. These are the arteries in the brain. This is one lot of arteries, and there should be some here. That's blocked. So after the treatment, you can see blood going in there. And this is one of the blood clots which has been retrieved following one of these operations. This treatment, and here I'm talking to the chief executive, because he were talking about investing. Thrombolysis was considered to be expensive. That was about £650 a shot. Thrombectomy is, if you get it cheap, 10,000. One of these devices, and you might have to use 2 or 3 for an operation, costs about £4,000. And then you have to have your theatre team and everyone on call. So this is very expensive. But cost effectiveness analysis have shown that it's definitely cost effective. So, and these are the trials. I won't go into it, but there are 7 trials published now from different continents, different countries, involving almost 2,000 patients, which have unanimously shown that thrombectomy is superior to just clot-busting treatments. The number needed to treat to have 1 more patient alive and independent is somewhere between 3 and 7, which makes it one of the most effective interventions you can have. You compare it with other things, operations for heart attacks, which are now standard, the PTCAs as we call them, the angioplasties. You need to do 20 to save 1 death. Thrombolysis to enable one more patient to be alive and independent, you need to do 11. For mechanical thrombectomy, it's somewhere between 3 and 7. So you can see extremely effective. And the third intervention, which is definitely, well, actually, I've got 4. Where am I going? So I've had 3. There's 4 here. Is the intermittent pneumatic compressions. They prevent thrombosis and improve survival. And that's what Bryn was talking about. It replaced the stockings, which were absolutely hated.
Yes.
The patients don't like the pumps either, I must say.
But they would if they tried the stockings.
But they probably would if they tried the stockings, yes. So, and they don't have the side effect of causing skin ulceration. So this is the sum total of something like 20 years of stroke research and positive results. So you can see how much in acute trials which save lives or save significant disability. So you can see how much research you have to do before you get something positive. There are quite a few negative trials here, so let's go through those. My study, my idea was that the brain after a stroke is starved of oxygen. If you give a bit of extra oxygen, maybe it would recovers better. And I tried that in a large group of people, over 8,000 patients, to give the oxygen, not to give oxygen when it's needed, but to give oxygen prophylactically, just in case it's needed during the first three days. And we gave it either continuously at night or only when the doctor thought it was required. It was taking place all over the UK. It certainly got the oxygen levels up, but it didn't do anything to recovery. Now, to show that picture to you, this is a modified Rankin scale. This is how we all measure recovery. It goes from 0, which has been back to normal, to 6, which is dead. And the other shadings in there are different levels of disability. And as you can see, at 3, 6, and 12 months, there is really no difference between the top of the 2 bars and the bottom of the 2 bars, the active treatment or the inactive treatment. So I'm afraid my own trial was negative, meaning that oxygen does not save the brain. It doesn't make a difference. If it's not obviously needed, don't give it. This may be very negative, but it's also positive because it allows us to concentrate on something else. So if the oxygen, giving it to everyone isn't good enough, maybe we have to find the ones who need it. Or maybe we have to find out why somebody has got a low oxygen saturation and treat that cause. So here I come to the next negative study and the hottest of the press, because that's only been published last week. It's a stroke IMF study, and again, a lot of centres in the West Midlands would have participated in that. The idea here is that one of the reasons why people have low oxygen saturations, low oxygen in the blood after a stroke is because they have a pneumonia. And since a lot of patients who've got swallowing problems develop pneumonia fairly quickly after a stroke, what's the point of waiting for it to get bad if you can give it prophylactically? So in this trial, they were randomized not by patient but by hospital. One hospital, all the stroke patients got the treatment. In another hospital, the stroke patients only got the treatment when they needed it. And they've had over 1,200 patients in the trial. But again, it made no difference. There is no reduction in pneumonia with prophylactic antibiotics. They did have a few more waterworks infections. But what was mostly feared, and some of the hospitals in West Midlands didn't take part because we all know that antibiotics are bad. You can get antibiotics if they're not needed, that you can get antibiotic resistance, and that you get C. difficile diarrhea. The great fears, it didn't even do anything to that. I mean, we're glad it didn't do anything to that, but it didn't even manage. It didn't prevent the pneumonias and didn't cause C. difficile diarrhea either. So again, back to the drawing board. Just giving antibiotics without a need doesn't cause any benefit. So we'll have to look at something else. But other negative studies, I think you can learn from any study. You can learn from the positive, because you can change practice. You can learn from the negatives, and you can learn from the ones you're just doing. This is a dire study. This was a new clot-busting agent, and again, the study turned out to be negative. But this required us not only to do a CT scan, but we also have to do an angiogram. We have to have a look at the arteries in the brain and where the clot sits. And that's something we didn't do in our hospitals. It's very rarely done in the UK for stroke patients, and if we did it, we did it 2 weeks later. Suddenly we had to do it as part of the research, and I've learned a lot about how to do it and how to interpret it. So this has given us knowledge, and it has prepared the way for us to do the thrombectomies. Because you can't do the thrombectomy procedure if you can't find where the clot is by the angiograms. So we learned a lot through that study. There's an Interact study. That was one looking at blood pressure control in patients with brain hemorrhages. And it was slightly positive, but just borderline. But the most important thing was that it didn't do any harm. So we don't have to worry if we treat the blood pressure aggressively. It taught us how to treat blood pressure very rapidly, because that's quite difficult. You've got to give an intravenous drip, and you've got to titrate your treatments. And it's given us confidence in blood pressure management. ENOS, another study about blood pressure. This one was looking at whether you should, after a stroke, just stop all your tablets for blood pressure, because it may be that the brain needs a bit higher blood pressure for the first week or two, or whether you can continue it, and whether you should support the blood pressure management by giving it a patch with a blood pressure lowering medication. Neither of those two made any differences. So whether you stop or start your medications, the stroke doesn't get any better or worse. And if you give the patch, it probably doesn't make a difference either. Although in a subgroup analysis where the patch was given really, really early, it may very well have quite a dramatic effect. But that group was too small to be sure about it, but big enough for us to look for more, and that comes into the future studies. One of the interesting things was, the only really positive bit in the study was that some patients who were given the blood pressure tablets after the stroke actually had much worse outcomes. And they didn't have worse outcomes because they had worse strokes, but they had worse outcomes because they had pneumonias. And they probably got the pneumonias because they were given the blood pressure tablets, although they couldn't swallow. So it just shows you that sometimes the findings you have relate to something completely different. They give you new ideas. This brings me to the new ideas, new studies. These are studies which are ongoing at the moment, and I won't go through all of them. The physicians here will recognize the names of those studies. What you can see here is that there's a good mix of acute, rehabilitation, surgical studies, and translational are the ones which develop our ideas and the underlying science about it. And the future studies, these are the ones which will be coming at some point. I mentioned the ENOS study, the blood pressure patch. This is now being given in the ambulance, and the study will start soon. The smart chip study, that Bryn was involved with that. This is one where there's a blood test, possibly for stroke. We know that some of the blood mediators go up immediately after stroke. Can we actually use it to have a finger prick to give an idea, like for diabetes, that stroke can be diagnosed? That's one study ongoing. The MAPS2 study is my study, is relating to preventing of pneumonia. We're looking here whether preventing vomiting after a stroke might reduce pneumonia, and whether putting in antibiotic paste into the mouth will reduce the infections, because most of the infections are caused by saliva and secretions from the mouth aspirated. But there are studies of new clot-busting drugs. There are studies of different ways of getting more blood to the brain. And there are a lot of studies looking at different ways of imaging so that we can pinpoint the patients who are most likely to benefit from the new treatments. So how do I think research improves practice? I suppose through the results, but also through everything we learned by doing the studies. Quite practically, the research has to be done by somebody. Having research nurses on the ward in an A&E means more hands on the deck. Research fosters critical thinking, and I think it gives us all hope. And all these things are important for improving services. I think that's the end of my presentation.